Good afternoon. My name is Joyce Coleman. I'm the Executive Director of the Vasculitis Foundation, and I'd like to welcome you to today's webinar. We're very pleased to have Dr. Robert Micheletti with us today. Dr. Micheletti is a dermatologist-internist with clinical care and teaching roles in both the departments of dermatology and medicine at the University of Pennsylvania. His clinical and research focus is on complex medical dermatology conditions, including vasculitis and inpatient consultative dermatology. The Department of Dermatology is a major referral center for severe dermatology disease with over 40,000 patients seen each year and offers a number of specialty clinics, including sarcoidosis, connective tissue diseases, and vasculitis. Dr. Micheletti is the principal investigator for the ARAMIS study, which is funded by the Vasculitis Foundation. During today's presentation, if you'd like to submit a question, please use the chat box or the question box. We will have a Q&A session after the presentation. So at this point, I'd like to welcome Dr. Micheletti to the webinar, and you have the floor.
Well, thank you for the opportunity to present, and thank you to those who are tuning in. I want to take a few minutes just to talk about vasculitis in the skin, and specifically why it's important, some of the ways that it can present, why we should care about this particular manifestation of vasculitis, and then also talk a little bit about the ARAMIS study and some opportunity to learn more about this group of diseases. I recognize that among the people who might be listening in, people have different types of vasculitis, different rates of skin involvement, different types of skin involvement. So with that being said, some of what I might say may be more or less relevant at different points of time, but I'll try to provide a general overview of what we see and what the significance of it is. So what is the significance of skin vasculitis? Well, I think first and foremost, it is helpful for diagnosis. The skin is the largest and most visible and the most accessible organ of the body. So if we might see vasculitis present first in the skin, it's also a place where we can biopsy easily to try to secure a diagnosis. Number two, it's an indicator of disease activity. And so skin vasculitis, as I mentioned, can be the first sign of disease or potentially an underlying trigger, or it could also be an indication of a flare. So vasculitis that's in remission when it's flaring possibly could present first in the skin. And then lastly, but certainly not least, symptoms, psychological, social impact, itching, pain, these kinds of things certainly are impactful for the patient, even if it's not necessarily life-threatening. And the visible nature of skin vasculitis means it's rarely out of sight, out of mind. So as long as you can see it or someone else can see it, it's on your mind. And so we care to treat it even, again, if it's not necessarily life-threatening. So I like to start with just a basic definition. Anytime there's something that's confusing, and I think vasculitis certainly can be that, I like to start with a basic definition. And, vasculitis is, on its simplest level, inflammation and destruction of blood vessels that results in downstream tissue damage. The diagnosis depends on finding characteristic clinical, that is what we see, in the clinic or on labs and so on, and biopsy findings. And they really have to match up in order to come up with a proper diagnosis. And the appearance, that is what we see, in this case on the skin, correlates with the size of the affected blood vessels such that the disorders are classified according to vessel size. So there's this rubric of each of these different types of vasculitis and whether they affect small and medium, or large vessels in the body. And the reason this is helpful is because once we know what size vessels are involved in a given disease, it allows us to predict what sorts of clinical manifestations we might see, and vice versa. It enables us to look at a patient or look at the skin and, based on what we see, be able to predict what diagnoses are most likely. And so for small vessel vasculitis in the skin, for instance, you might see what we call palpable purpura, which are flat and raised purple spots on the skin, hive-like lesions, urticarial papules, blisters, little purple dots. For medium vessel disease, you'll see larger lesions, so what we call livido-reticularis, this kind of net-like purplish process, retiform purpura, which is basically bruising that's in a jagged pattern, or ulcers or nodules under the skin. And the way I like to sort of conceptualize this is with what I refer to as this tree drawing, which represents essentially the vasculature of the skin. So down in the deeper portion of the skin and the fat underneath the skin, we have medium-sized vessels, and I liken that to the trunk of the tree. And then the superficial branches of the tree correspond with the small vessels in the upper part of the skin. Okay, and so for small vessel vasculitis of the skin that's mediated by what we call immune complexes, we see those complexes deposit in these superficial vessels, and that triggers off this whole cascade of inflammatory response, where these inflammatory cells come in, they destroy the vessel, and we get blood that leaches out into the skin, and we refer to that as purpura, the sort of bruise-like appearance. Now the lesion is raised because of the inflammation, and it's itchy or it burns, it's painful because of the inflammation that's there. And so we can see palpable purpura, which here again you see sort of this purple bruise-like flat and raised lesions. You can see hive-like lesions. Here we have blisters, actually little blood blisters, sort of on a background of purpura. And you can also develop ulcerations from the individual lesions kind of running together and creating a rounded ulcer. And so these are all manifestations that we might see in what we refer to as immune complex-mediated small vessel vasculitis. So if you've been diagnosed with Henoch-Schönlein purpura or cryoglobulonemic vasculitis or hypersensitivity vasculitis, small vessel vasculitis, these are all this would be common manifestations for any of those conditions. For medium vessel vasculitis, now we're impacting the trunk of that tree, and so the whole overlying area is impacted, and you can see livido-reticularis or retiform purpura, and I'll show examples in a moment. If the insult is significant enough, you can have necrosis or death of the skin and ulceration. And so livido-reticularis, you can see this kind of net-like purplish appearance. The way I explain this is, thinking about the tree and looking at it from above as though you were sitting above the forest canopy, and then realizing that there are a lot of other trees in that forest, and they all have interlocking or intervening branches. It explains how it is that you have territories of affected, unaffected, affected, unaffected skin that creates this sort of net-like purple and white alternating appearance of livido-reticularis. If the insult is more significant and you sort of draw a dot to dot from branch to branch of this tree, again looking from above, you can understand how it is we get this kind of jagged appearance that we refer to as retiform. And the word retiform or reticularis just means net-like. Again, that sort of jagged appearance. And then again, because this area of skin has lost its blood flow, you get an ulceration. And it is a jagged shape because it's a medium vessel process. So just to drive the point home, in small vessel vasculitis, the small vessel involvement accounts for the small size of the lesions. The inflammatory response accounts for the raised, palpable nature of the lesion, as well as the symptomatology, the burn or the itch. The red blood cell extravasation, leaching out from the vessels that have been disrupted, results in this non-blanching purpura, that purple appearance that's fixed in the skin and doesn't go away. And the effect of gravity on these immune complexes as they deposit and settle out accounts for why it is we see this mostly on the lower legs. And so if we see this kind of manifestation, we'll be thinking about small vessel vasculitis or a condition that can affect small vessels. Now, if we see other types of manifestations, nodules under the skin, livido-reticularis, retiform purpura like this, ulceration, these kinds of things would make us think about a more significant hit to the vessels of the skin, for instance, a medium vessel process, a vessel deeper down that's getting impacted. And so diseases like polyarteritis nodosa, ANCA-associated vasculitis like Church-Strauss or granulomatous with polyangiitis, cryoglobulonemic vasculitis, we would be thinking about those entities. So using the skin exam alone, we can narrow the differential diagnosis and what we think we're seeing considerably. And we can go through this in each organ system in turn. And if we think about the kidneys, the small vessel is the glomerulus. And here, immune complex is deposited, inflammation follows, and the filter of the kidney, because that's what the glomerulus does, isn't working well anymore. And you see blood and protein spill out into the urine. And that's why we check urine samples to look for that. And so conditions where small vessels are involved, you can see glomerulonephritis, which is the term for what's happening there with the glomerulus, and includes the conditions that I've shown here. And we look for things like red blood cell casts, which signify that the bleeding is actually coming from the kidney. For medium vessel vasculitis, these vessels are actually macroscopic. You can see them on a special kind of CAT scan, a CT angiogram. And so you'll see dilation of the vessels or narrowing of the vessels, and that results in not blood and protein in the urine, but rather high blood pressure. And this is what those little aneurysms look like on the angiogram. So this would be consistent with polyarteritis nodosa. And so, again, you can see how it is that based on what we see clinically, we can begin to predict with some degree of certainty kind of what diseases we're most likely to be encountering. But how can we really prove it? Well, here again, the skin is quite a useful thing to us because we can easily biopsy the skin. It's not as difficult as biopsying other organs. And so if we're able to biopsy a spot of purpura, for instance, and we show that there's blood vessel destruction and there's a typical pattern of inflammation, then we can confirm that, yes, in fact, there's vasculitis here. Now, the reason we want to do this is there are other conditions which can look similar to vasculitis and which we have to differentiate between. And some people may have had the experience of searching for a diagnosis. You have symptoms, there might be some ideas of what's going on, but until we get all the pieces of information together, you may not be able to confirm a diagnosis of vasculitis. And so getting a skin biopsy sometimes can be a way of doing that. And again, the skin is by far the most accessible and the safest to biopsy, and provides, for that reason, a good opportunity. This is what vasculitis, small vessel vasculitis of the skin looks like. And so the arrows are actually pointing to where vessels are supposed to be or used to be. And what you should see, this is actually a little kind of like a sweat gland over here that I'm circling with my pointer. But normal vessels, you should actually be able to see an opening. You should see where the blood should go. But here, the inflammatory cells have destroyed the vessel completely, and blood has kind of leaked out into the skin. And this would be diagnostic of a small vessel vasculitis. Here's a medium vessel. You can tell it's a medium vessel because it has muscle surrounding it, and you can see all these little purple dots in here inside the vessel. These are the inflammatory cells that have essentially destroyed the vessel. And so now any blood that's trying to flow through this vessel and get to the skin is being disrupted, and so the overlying skin doesn't have good blood flow, and so it creates pain. It creates a skin lesion that you can see. So again, the diagnosis is a very important thing that the skin can help us with in vasculitis because it's the largest, most visible, and most accessible organ, and it can be really a key to helping secure a diagnosis. Now, at the same time, it can be an indicator of disease activity. And I like to remind physicians when I'm talking about vasculitis, let's say to a group of dermatologists, I like to remind them that skin lesions of vasculitis really are a symptom of the disease rather than a disease entity in and of themselves. And what I mean by that is that when we see skin lesions that we think are vasculitis, what's really important is to make sure that there aren't other areas that have vasculitis, like the kidneys or the joints or the gastrointestinal tract. And at the same time, there might be some underlying disease or trigger, an infection or medication or autoimmune disease like lupus, that can actually trigger vasculitis. Certain types of vasculitis can be triggered by these sorts of things. And so we might be interested not just in making the diagnosis of vasculitis in the skin, but knowing that there's an underlying other thing going on that we might have to address. So each of these things, of course, affects the prognosis and the management. So when we see palpable purpura, that is raised and flat purple spots on the skin, and we suspect vasculitis, our work isn't over. We're not satisfied with that. We have a little bit left to investigate to sort of figure out what the significance of that vasculitis in the skin actually is. So this is when the doctor will ask a bunch of questions. Do you have joint pain? Do you have belly pain? Any blood in your stool? Any cough? Any numbness, tingling? These kinds of questions are geared toward understanding, could there be vasculitis in other organ systems? And that's what we call our review of systems, and certainly the physical exam, taking a thorough look at everything, along with some basic labs and really any further lab workup that's dictated by an abnormal symptom. And importantly, vasculitis can be confined to the skin. There are many patients who just have vasculitis only in the skin, but systemic vasculitis, that is, involving other organ systems, and any underlying disease states or triggers need to be excluded in order to feel comfortable that really it's only in the skin. So this chart here is actually only applicable to the common type of small vessel vasculitis that we see in the skin. But when we see that, about half the time, it's what we refer to as idiopathic. That's a word that means we have no idea what caused it. About 15% of the time, there's an underlying infection, 15% of the time, a medication, 15% of the time, some kind of autoimmune disease like lupus, for instance, and 5% of the time, or probably less than 5% of the time, there can even be a cancer that's triggering the small vessel vasculitis of the skin. So these are the kinds of things that we'd be looking for. Now, probably skin lesions and vasculitis are helpful for more than just diagnosis and possible underlying trigger and so on. It may have some indication for the severity of the overall disease. So this is a study called the Diagnostic and Classification Criteria in Vasculitis Study, or DCVAS. This is a study that's purpose is to help determine criteria for diagnosing vasculitis. And we look back at some of the patients in that study, about 1,200 patients with ANCA-associated vasculitis, so microscopic polyangiitis, eosinophilic granulomatous with polyangiitis, or Church-Strauss, and granulomatosis with polyangiitis, or Wegener's. And among those patients, those who had skin lesions of vasculitis were more likely to have systemic manifestations of disease, so vasculitis involving other organs. And in particular, patients with skin lesions were more likely to have severe manifestations like glomerulonephritis or kidney involvement, alveolar hemorrhage or lung involvement, or mononeuritis, which is nerve involvement. And actually, those patients with skin lesions had a double the risk, at least among the patients with granulomatosis with polyangiitis and eosinophilic granulomatosis with polyangiitis, double the risk of having severe manifestations in other organ systems. So for that reason, we'd say maybe the skin is actually also helpful for prognosis and indicating the risk of there being other stuff going on. So that's why I say the skin is important, because it can be an indicator of disease activity, the first sign of vasculitis, or possibly an underlying trigger, or an indication of a flare. And I would really think of it as a quote-unquote red flag for something going on, which may be important or might not, but we need to investigate that. We need to figure that out. And I think the third reason, again, not the least, but the last here to talk about, is symptoms, the psychological, the social impact of having vasculitis in the skin. And what are those symptoms? Well, these small lesions, this is palpable purpura, these purple kind of raised and flat lesions, or hive-like lesions that patients can get, these burn or they itch. Larger lesions, here's some retiform purpura, or skin nodules. They can ache or be painful. They can be tender. If you get an ulcer, certainly that's painful, and it's an open wound. And especially if you're on prednisone or other medicines, this is a risk of infection. And so there's a lot going on here that we might want to address. But even when skin lesions of vasculitis aren't itchy or painful, they are visible. And that's one of the things that that's a daily issue for us in dermatology, is that even for somebody like me who mostly treats complex medical dermatology where there almost always is some other systemic disease going on, at the end of the day, the patient often cares the most about what is visible on their skin, because it's like wearing a badge of your disease around. We don't like to necessarily think of it that way, and I think most people think that people are noticing things more than they are actually noticing things. But at the end of the day, it's absolutely true that this affects patients, and they don't like having these spots. And so even if something isn't quote-unquote medically serious, it can be important to the patient. And so that's why we want to treat it. there's this feeling of being on display. People may worry that there's a serious condition which might be starting or might be coming back if it's been treated and is thought to be gone, it might be coming back. And so even though it hasn't been studied in a systematic way, we surmise that the quality of life impact of skin vasculitis is probably significant. And this is something that actually we are trying to study through the patient-powered research network using a survey. So to try to better understand what's the impact of having skin vasculitis on patients and how they feel about their disease. How do we treat vasculitis of the skin? Well, the choice of treatment is really dictated by the workup. So what I mean by that is if we discover that there's kidney involvement, or we discover that the skin vasculitis is part of some more serious internal vasculitis, obviously we're going to treat that aggressively. And if we find that the skin vasculitis is triggered by something else, we're going to try to address that. And it makes sense that the more significant the internal disease is, the more significant the therapy needs to be in most cases. And in most cases, whatever we decide to treat with will control the skin, but not always. And I've certainly seen patients who are given reasonably high doses of prednisone for their vasculitis, but the skin lesions just keep coming. So we have other ways of trying to address that. Simple things can be helpful. So especially for immune complex mediated vasculitis. Now remember, this is caused by these little antibodies and antigens in the blood that kind of settle out due to gravity. So prolonged walking, sitting or standing, excessive heat, these kinds of things can precipitate flares. And so we might tell people to wear compression stockings, or certainly if they're on a long flight or if they're going to be on their feet all day, this can actually prevent flares on the legs of immune complex mediated vasculitis. Topical steroids like triamcinolone cream, this is not going to prevent new lesions, but it can certainly help decrease inflammation and provide some itch relief. So we can prescribe that to help. And then just basic sensitive skin care and moisturization. So any itchy skin, you at least will get temporary relief from a good, bland, unscented moisturizer, or Sarna lotion is a over-the-counter anti-itch lotion, which I like to recommend a lot. People tend to feel like that is helpful for itch, and you can put that on, as many times a day as you like, for itchy skin. And so these are some sort of practical things that patients deal with. How about dark marks? So you have a spot, the spot goes away, but it leaves behind this dark mark. This can be challenging to make go away, but I'd say avoid picking and scratching, because any inflammation of the skin is what causes the post-inflammatory hyperpigmentation, and so we want to minimize inflammation by trying not to pick or scratch the lesion. Excessive sun, this can also cause them to darken up, so keep them covered or use sunscreen to prevent darkening. There is a lightening cream out there, but it's hard. You can imagine if people somebody has multiple spots, it's hard to put the cream on all these little spots, so it may not be a practical solution, but sometimes we might do that for dark marks that are bothersome. Wound care really depends a lot on the wound and the situation, so it's hard to give specific advice, but essentially, from a dermatologist perspective, when you have open skin, we want to keep it clean with soap and water once a day, just kind of let the soapy water run over it, and we want to keep it covered. So we like things that are non-stick. So basically, if you have a dressing that is pulling or causing pain when it's changed, ripping new skin off, that's not good. And so we like to use non-stick gauze like Vaseline gauze or Telfa. We love Vaseline because it creates this sort of moist, protected wound healing environment. Or mupirocin ointment is a topical antibiotic that is in a Vaseline consistency. And we do like this antibiotic the best. Some of the others like bacitracin or triple antibiotic, people actually can get allergic to that. So we tend to recommend this one instead. And then compression. We mentioned before about compression stockings, possibly preventing certain types of vasculitis skin lesions, especially on the lower legs. When you have a wound on the lower legs, that's an area that's very difficult to heal because the circulation isn't so great. There's a lot of blood that sort of pools in the legs, and so compression stockings or ACE bandages, things like that, work to push the fluid back up the legs where it needs to go away from the wound, and this helps aid wound healing. So whether vasculitis involves the skin only or remains active despite treatments that are predominantly aimed at other organs, the treatment of skin vasculitis specifically should be symptom focused. So what this means is basically that unless someone has painful ulcerations or really over-the-top skin lesions of vasculitis, I try, in most cases, especially if it's limited to the skin, I try to avoid using things like chronic prednisone just because there are a lot of side effects associated with that. And if we can get away with something that doesn't have all those side effects, that would be better. Unfortunately, we really don't have a lot of data. And when you talk to your physician and they talk about data and why they're doing what they're doing, really what that refers to is studies that have enrolled patients like you, preferably, that have proven safety and efficacy of a particular treatment. And in skin vasculitis, we really don't have a lot of that. There's only been one small randomized controlled trial for a medicine called colchicine. It only had 20 patients in each arm. 20 of them got the medicine, 20 of them didn't. And it really didn't show anything. The study was too small. It only lasted a month. It didn't show anything. We tend to use a lot of other medicines. I've listed some of them there. This tends to be based on expert opinion or what we call case reports or case series where people report, I did this in 5 patients and it worked well. And that's good. It's helpful, but it's limited. How applicable is it? And so depending on really which doctor you see, they might make one of these recommendations or a different recommendation. And so that to me is not optimal. We need to do better than that. And that leads us to the study that Joyce Coleman mentioned at the very beginning, which is a study called ARAMIS. And this is a study that's being supported by the Vasculitis Foundation, which we very much appreciate. And it's going through the Vasculitis Clinical Research Consortium, which is a group of predominantly rheumatologists around the country and in Canada that study vasculitis. And until now, there really hasn't been any large-scale attempt to study skin vasculitis. And what this study is doing is it's enrolling patients who have what we call skin-limited vasculitis. So this includes people who have a diagnosis of cutaneous polyarteritis nodosa, so it's only in the skin, IgA vasculitis or Henoch-Schönlein purpura, as long as it's mostly or predominantly in the skin, so that you don't have any kind of significant kidney involvement, for example. And the third type is what we refer to as cutaneous small vessel vasculitis or leukocytic classic vasculitis. It's typically a skin-only type of vasculitis. And we basically are taking these 3 medicines, colchicine, dapsone, and azathioprine. These are all 3 medicines that people will, often a doctor will just talk about one or more of these, and you'll just choose one. And it literally is not any more scientific than that, because they all have sort of the same level of data to support them. And in this study, we are having the computer pick it for us, and we are then keeping track of what happens in a very systematic way, with the goal being that by the end of the study, we hope that we might be able to say, colchicine works the best, for example. So everyone should start colchicine first. It's well tolerated, so on and so forth. And in the study, if we choose one of these medicines and it doesn't work, then there's the option to be re-randomized to one of the other 2. So you're not stuck on one drug if it's not working. So that's the basic framework of this study, and we've got a lot of different sites I'll get to in a moment that are partnering up about this. There is a sister study. This study is called CUTIS, and this study actually is looking at any type of vasculitis, not just skin limited, but any type of vasculitis, as long as there is a skin lesion of vasculitis. And what we're doing in this study is simply a biopsy of the skin lesion of vasculitis, and we also take some blood. And the idea here is to do what we call gene expression analysis to understand what pathways of inflammation are upregulated in the disease. And we're also looking very closely at the features of these biopsies as we collect them. And the goal here really is to get away from just classifying vasculitis by what size of vessel is involved and getting on more of a basic level of what's the actual pathway that's involved, so that instead of just giving prednisone, for example, maybe there's a specific drug that will hit that one pathway and help that disease. And so we are partnering with a group at the NIH to help do this study. So these 2 studies kind of go together, and really anyone with skin lesions of vasculitis can be involved in the CUTIS study. patients with skin-limited vasculitis can be involved in the ARAMIS study, where we're looking to figure out what the best treatment is. And as I mentioned, these studies are both enrolling now. University of Pennsylvania is the main site. We've been enrolling for several months now. But each of these centers, Boston University, Hospital for Special Surgery, Cornell, Mayo Clinic, Northwell in New Jersey, Oregon Health and Science, Penn State, Kansas, Utah, and Mount Sinai in Toronto are all now open for enrollment. And then there are several sites that are coming along soon. And so depending on where someone is, there might already be a nearby site that's open, or there might soon be a site that's open in the U.S. or in Canada to accommodate folks who are interested in participating. And of course, if there's a question, I'm happy to field questions and try to steer people in the right direction if they're a candidate for the study or not. So I think, no question, the symptoms, the psychological and the social impact of skin vasculitis is important, whether it's itching or pain, or it's simply the fact that it's there. Whether other people can see it or only you can see it, if it's visible, it's on your mind, and this is something we want to make better. We really need to address these issues and learn more about both how to treat skin vasculitis successfully, but also what the impact of it is on patients, and that's what both the Quality of Life Survey and these two studies I just mentioned are aimed at doing, is just making a better impact on this particular sliver of what patients with vasculitis are dealing with. Again, recognizing that the skin may not be as quote-unquote important as the kidney, but it doesn't mean that it's not something that's impactful for people who have skin vasculitis. So in summary, skin lesions, I think hopefully anybody who has them can agree, and hopefully I've convinced those who don't, that they're important, and they're an important manifestation that we see in many different types of vasculitis. They can be a sign of underlying disease, or they can be a sign of systemic vasculitis, or they can be important simply because they're there, because they're painful or they're distressing. And this is really an important part of vasculitis for those who have it, deserving of special attention. And dermatologists can be useful partners in diagnosis, treatment, and skin care, both useful to the rheumatologists and other providers to help confirm a diagnosis, useful to help identify maybe when a relapse is happening, but also useful to try to manage and treat the symptoms that patients are experiencing. Even if you're on a regimen for your vasculitis otherwise, we sometimes can add things specifically for the skin that can deal with any residual involvement that we see there. So I wanted to leave time for questions. So I'm happy to field any that people have.
Great. Thank you so much, Dr. Micheletti. That was a great presentation. It's probably one of the best webinars we've ever had, so thank you so much. So I had a question that came in via email, so I'll ask it real quick. Do you have an opinion on the sleeve stockings? They're stockinettes. Do you think those bandages work well, or do they cover too much area?
Just to make sure I'm thinking of the same thing, there's something that we use it's also called like a tuba grip stocking.
Yes.
And it's basically like a tubular kind of stretchy tan colored sort of sock or bandage. And I like those. I like them because basically what I say about compression is if you have a wound on your lower leg, regardless of whether it's vasculitis or not, the edema, the swelling that we see in the lower leg is the primary impediment to wound healing. So whatever compression I can get, I will take. So the tuba grip is probably the least amount of compression. It's not very strong compression, but it's much easier to tolerate. So if it's painful, often people can't put on compression stockings, or they can't put on special dressings like an Una boot, for example. So we might start with the tuba grip just to kind of, you've bandaged up everything, and then we put the tuba grip on over that to provide some compression to start getting rid of swelling. You also keep your feet elevated, begin to get rid of the swelling, and then over time, as the swelling goes down and as we treat the condition, then you can graduate to, maybe compression stockings or ace bandage, co-band dressing. These are all other ways of trying to add compression. But yeah, I like the tuba grip or sleeve kind of dressing as a way to get at least some compression.
Okay, great. Thank you so much. So at this time, I'd like to introduce Kaylin Young. Kaylin is the manager of the VPPRN, our Vasculitis Patient Powered Research Network, and Ed Becker is our Director of Marketing and Communications for the VF, and they're coordinating the questions that have come in through the audience, social media, and also anyone in the audience who has a question, please feel free to use the chat box or the question box to submit your questions. So Kaylin and Ed, do one of you want to take it over?
Sure. We've had a couple of questions come in, and again, Ed and I are both fielding them. So Ed may have some additional questions. But one is actually about, is there any eye toxicity associated with the drugs, with topical treatments or drugs in people over 65?
Well, the main, so I think it depends on how you define it. I think prednisone certainly has eye toxicity. And chronic prednisone, has a lot of issues. And so prednisone is kind of a double-edged sword. It works well to control inflammation, but once we've got the inflammation under control, we're doing our dead level best to get you off prednisone. And so glaucoma and cataracts are two things that can be associated with prednisone. And if you have to be on prednisone, then certainly managing those conditions or following along with an ophthalmologist if those things exist. As far as the other medicines that I talked about, not really any particular ocular toxicity. There's a medicine called Plaquenil or hydroxychloroquine that people use a lot for lupus and other connective tissue disease or autoimmune disease. And that medicine has a risk of ocular toxicity. Specifically, people get visual field deficits. And so for that, anytime somebody started on that medicine, we'll have them get a baseline eye exam, and then we usually recommend annual eye exams, although the eye doctors will usually say it takes like 5 years to have a problem. But I didn't mention that one. That is sometimes used for skin vasculitis, Plaquenil, and there is that kind of rare incidence of eye toxicity to be aware of with that medicine.
Great, thank you so much. So another question from the same person is it safe to take one baby aspirin a day with this condition? So if you have skin involvement with any of the vasculitides, is it safe to take baby aspirin daily with the mix of other medications, et cetera?
Yeah, I mean, I think that in general, it's okay. I would say that it's always a good idea to run it by your regular doc, because obviously it'll vary. So if somebody's on blood thinners for other reasons and they add an aspirin to that, then it increases the risk of unintended bleeding, which isn't good. But absent something like that, as long as there's not some reason why somebody shouldn't be on aspirin, just simply having vasculitis in the skin isn't a reason, not to have it. It won't, even though we're saying, there's bleeding into the skin. It's not that the aspirin necessarily makes that happen or necessarily makes it worse. It's the vasculitis that's making it happen. So in general, no, not an issue, but it's always good just to run it by your regular doc.
Great. Well, thank you so much. Ed, do you have additional questions?
Yeah, a few questions have come in the past couple of minutes, and you may have covered some of these, but I'll just ask them anyway. First question is, can cutaneous PAN become systemic PAN where the organs become affected? Can it start out as a cutaneous and then become a
Yeah, that's a great question, actually, and I've actually looked into this question quite a lot. Technically, the technical answer is yes, but I'll put a big asterisk on it. So the study where that comes from is a study where they followed 22 patients, and 2 out of the 22, so roughly 10%, later went on to develop systemic complications, and I'm talking like 10 years later or even more. That being said, there's another study that was a lot bigger, so 77 patients out of the Mayo Clinic, and 0 of those patients with cutaneous PAN went on to develop systemic manifestations. And the way I interpret that is basically that when you get a diagnosis of cutaneous PAN, the important thing for the doctor to do is to ask all the questions about other stuff going on. Often I will do, some imaging and other workup to make sure that I really am convinced that it's only in the skin. And certainly, if anything new crops up, new symptoms or whatever, we're going to investigate that. But my opinion is that based on the literature, my opinion is that if you properly categorize someone to begin with, the chances of it turning into a systemic PAN is either 0 or close to 0, depending on how you want to interpret those studies. How well were they done? Because it's all retrospective. Somebody's looking through a chart 10 years later and trying to figure it out. So I think the risk, if there is risk, it's quite low. But it's important for people to be accurately classified to begin with, if that makes sense.
Yes, thank you. Next question is, my dermatologist tells me, or is diagnosing me with cutaneous vasculitis. Should I remain with the dermatologist, or should I go under the care of a rheumatologist?
So that's a good question as well. So, I think every situation is different. I think that for me, the main reason to involve a rheumatologist is if there is more systemic stuff going on. If there's kidney involvement or nerve involvement, these kinds of things, typically it's good to have a rheumatologist or a kidney doctor, if it's the kidneys, involved along the way. If it's skin limited, then you might be best off in the hands of the dermatologist. It sort of depends. Some dermatologists are, interested and very capable in managing the, skin vasculitis, and they're going to be the best place, for you to keep your care. If, on the other hand, you have the sense that, that they, that they haven't they haven't thought about other stuff going on, or they haven't asked about that, or they haven't gotten at least some laboratory workup to kind of help with that, urine samples, things like that, then it certainly doesn't hurt to get a second opinion. But I think bottom line is if it's limited to the skin, vasculitis limited to the skin, or with very mild systemic symptoms, then probably the dermatologist would be the best place to be managed, if that makes sense.
Okay, thank you. Last question. Can skin vasculitis leave permanent scars?
Yeah, unfortunately it can. There's anytime there's an ulcer or there's significant enough inflammation, then the natural output of that is a scar. Now, I do want to draw a distinction between what I spoke about before, the hyperpigmentation and scar. Okay, so hyperpigmentation is basically a dark mark, or hypopigmentation is a light mark, and that can result from inflammation of the skin and slowly fades over time. So that's not necessarily permanent. But a true scar, whether there's a wound or, after the wound heals, there's kind of like a shiny, white or pink spot, those scars are permanent, or at least semi-permanent. They'll look better over time, but they certainly stick around in one form or another. And that's so all the more reason for us to kind of get a handle on stuff. And again, good wound care, decreases the risk of scar. Avoiding manipulation of the lesions, not picking and scratching, that lowers the risk of a scar. So there are things that can be done to try to limit that part of the process. The good news is that certainly most scars are going to be less visible than, the purpura bruise-like component. And some things can be done, like if the scar is pink or something like that, And if it's really bothersome from a cosmetic perspective, there are certain types of lasers that can be used to get rid of the pink color, for instance, so it's more of just white or flesh colored. So there's a lot that can be done, if needed.
Okay, great, thank you.
Right. So there are a couple questions that came in. There's one, if there are no skin manifestations during the initial diagnosis, the patient has EGPA, Church-Strauss, is it likely that they will be a part of a subsequent recurrence?
Good question. So, as I mentioned, it really depends on the type of vasculitis, what we see. So for EGPA, the studies out there suggest that maybe up to 2/3. The study that we did, closer to 40-something% of people, have a skin manifestation. Actually, the 40% number that I throw out there is more akin to like the original presentation. The 2/3 may be more akin to during the course of the disease at some point. And Church-Strauss is an interesting one because you see both non-specific skin lesions and specific skin lesions. What I mean by that is one of the reasons that EGPA, Church-Strauss, is hard to diagnose is people first have asthma, sinusitis, those kinds of symptoms that anybody can have, and it's not necessarily vasculitis. And by the same token, they get skin lesions that anybody can have that's not necessarily part of vasculitis. So, for example, hives or itching or quote-unquote rash. And so we found in our study that patients with EGPA were much more likely to present with one of those non-specific skin manifestations like itching or hives. And it's only later on, during the latter phases of the condition when it really manifests as a vasculitis, maybe at the time that somebody gets their diagnosis, that you see other manifestations that you might think of as vasculitis, like the palpable purpura or the livida reticularis, some of these other manifestations. So that's a long-winded way of saying that you may have had skin lesions that were part of your EGPA without even realizing it, hives and stuff like that. If you haven't had any skin manifestations of the EGPA, fingers crossed, hopefully you won't. There's always a chance that if the disease were to relapse or come back, that it might manifest in the skin. Although, I would suppose that if it hasn't happened yet, it's probably less likely to happen down the line. But, part of the value of being able to look at and examine the skin is that, as I mentioned before, that might be the initial, place where it comes back. Now, this is not to say that, anything that people get on their skin, they have to be worried, oh my God, is this vasculitis coming back? I really don't want to give you that impression, but the point rather is if there's something that's going on that's similar to how it happened before, or if it's new and it's not just like a one-time deal, but it's like a persistent thing that's cropping up and it's a change for you, then that's something that you might want to bring to the attention of your dermatologist or rheumatologist just to check out. I hope that answers the question.
Okay, great, thank you. So we've had several people ask, could you tell us more about how to sign up for the studies?
Yeah, so I'm going to go back. I'll just go back quickly to the slide where I talked about where the different sites. So, I think that the first thing would be if you're in the catchment for one of these places, that might be a natural fit. But, some of these places, there's not a site that's open yet, or you might be in a place that's not near any of these places. And I think that as far as telling, would you even be eligible, or is this a good idea for me? What we could do is we certainly could kind of discuss, remotely. Let's say, again, if you're near one of these sites, that might be the right place to reach out to, or with me or my team. There is, I should have put this on here, but clinicaltrials.gov, and you can go on there and you can search for it. Actually, there's like the first page is a search function for studies, and you can put in skin vasculitis, and these studies will actually pop up, and ARAMIS and CUTIS, and you can it actually lists the contact people, ways to contact. So that would be one way. We also, I can give the I can give the number for our research coordinator as well, if I can manage to pull it up while my screen is being shared here. But those would be some ways. So actually, the research coordinator here at Penn is Michelle Hampton, Hampton, and her phone number is 215-360-0413. And again, you might not be anywhere near Penn, but if there's a message that comes in like, oh, I'm in Oklahoma, but I'm interested, then usually what I'll do with that is I'll say, well, I know this great guy down at UT Southwestern who's going to be up and running soon. If that's close by, if it's not, we can talk about, does it make sense for you to try to travel to someplace like that or not? We're happy to help. I mean, we're here to help, and if there's a way that you can be involved, great. If it's not, if it's better, if it doesn't make sense, and a different treatment is better for you, I'm fine saying that too. I mean, I think at the end of the day, what we're looking for is what's best for the individual patient. But yeah, certainly we're happy to take anyone who's interested in these studies and who fits the criteria for what we're trying to figure out.
Okay, great. And we'll have that information on the VF website also. Another question that came in, we just have a few more minutes. Do you have experience? Well, first the attendee said, excellent presentation. Do you have experience using biologic therapy with cutaneous vasculitis?
I do, but I think that usually that needs to be in a specific scenario that calls for it. So, there are reports of using various biologics like TNF inhibitors or rituximab, for example, for skin-limited vasculitis that has failed everything else, or it's highly symptomatic, it's causing ulcers, stuff like that. I would have to say that for some of these more aggressive regimens, or more immunosuppressive regimens, I think that whatever is going on needs to justify it if it's skin limited. And we also have experience in, let's say, the skin vasculitis is part of a systemic vasculitis or part of another disease process where we want to reach for that medicine. So, patients with rheumatoid vasculitis, so vasculitis due to rheumatoid arthritis, or vasculitis with another underlying disease state, where it makes sense to use a biologic, and it also treats the vasculitis. Great, So yes, I have experience using it for skin vasculitis, but it needs to be like the right scenario. Okay,
great. So we have a patient who asks about urticaria vasculitis and thyroid involvement and glytin.
What was the last?
Any thoughts?
What was the last thing?
Glytin, Gliten.
Not gluten.
It might be gluten.
I don't know.
It's written. Yeah, I don't I thought maybe it was gluten, but I'm not sure.
Yeah, it might be. Well, I'll just say, so urticarial vasculitis is it's a rare subtype of vasculitis that, in my experience, it can be hard to pin down. So I'll say that as somebody who is very much interested in seeing patients with any type of vasculitis, the number of times that I've had a patient referred with urticarial vasculitis, most of the time it ends up not being urticarial vasculitis, and it might just be chronic idiopathic urticaria, chronic hives, or some other process. And so I really like to make sure that we know we're treating the right thing. Urticarial vasculitis itself, is there an association with thyroid disease or with gluten-sensitive enteropathy or celiac sprue, gluten sensitivity, these diseases? Not really. For hives, chronic hives, there is classically an association with thyroid disease. Not that the thyroid disease is causing the hives necessarily, but rather that just the two coexist because they're both forms of autoimmune disease. So a lot of patients who have chronic hives they have an antibody that's making the hives happen. And so they might also have antibodies or other autoimmune process that's affecting the thyroid, or an autoimmune process that's resulting in gluten sensitivity. So in that sense, yes, when we have patients with chronic hives, we note that there is a rate of coexistence of those and other different types of autoimmune disease that kind of run along with the chronic hives in some cases. But as far as urticarial vasculitis goes, I don't know of a really specific connection with thyroid disease or with gluten sensitivity.
Okay,
But it's
great.
possible if you've read that there might be some bleed over from other literature about relating to hives, because as I mentioned, it can be really hard to tease these things apart sometimes. So it's possible that there's a little bit of misinformation that's kind of bleeding over from one group of literature to the other.
Mm-hmm. Okay, thank you. So there was one. This will be the final question. And it just says, can you comment on itch relief? And I think you kind of addressed that earlier in the presentation. But any final thoughts on people who are suffering from itching?
Yeah, so I mean, I think itching is a really important topic that tends to get underemphasized. It can really drive you nuts. If you're not sleeping, if you can't concentrate on stuff. So this is not something that's one size fits all. So advice for like kind of garden variety itch may be quite different than advice for somebody who's truly like unable to sleep, for example. But in general, good sensitive skincare is helpful. So we say like gentle soap like Dove, no washcloth, warm water, not hot water in the shower, short showers, 1 shower a day, not more than that. Moisturizing the skin with a thick, bland moisturizer cream that comes in a jar rather than lotion. The thicker, the better. Simply because dry skin is itchy skin. So we want to just kind of take that out of the equation. And then I mentioned there's an over-the-counter anti-itch lotion called Sarna, Sarna, that people like. It has menthol in it, so it's kind of a cooling sensation. You can put that on as often as you want for itching. Sometimes we recommend putting it like in the refrigerator so it's cool, so it feels maybe even more of a relief. Topical steroids that can be prescribed, like triamcinolone, hydrocortisone 2.5%, many others are out there. These are good for inflammatory causes of itching. So if you have hives or bug bites or vasculitis, this steroid medicine can kind of calm the itch. And then there are many, many other things to use. Benadryl sometimes is helpful, and then there are oral medicines that are targeted to the nerves and how they transmit itch. So medicines like Remeron or Cymbalta or others that relate to kind of nerve firing. So you can understand how it gets quite complicated actually after a while, depending on why the person is itchy. But suffice to say, a good starting place is sensitive skincare, moisturize the skin, Sarna lotion, topical steroids, and so on. And if it doesn't respond to that, then I'd say, consultation with a good dermatologist just to kind of make sure we understand exactly what's going on with the itch.
Thank you again, Dr. Micheletti, for sharing your expertise and knowledge with us today. We very much appreciate you taking time out of your busy schedule to help us with this webinar. I'd also like to thank Kaylin and Ed for coordinating the Q&A session. Before we wrap up today's webinar, I just wanted to share a few things that the Vasculitis Foundation is working on, and I hope that you will consider getting involved if you haven't already. We'd love your participation, and if you ever have any questions about participating, please just drop the VF an email, vf@vasculitisfoundation.org. One of the first things we're very excited to talk about is our VF Bob Awareness Campaign, which we launched in late January. The campaign is a fun way to capture the spirit of Bob Saws, who was one of our greatest advocates. Bob believed in raising awareness everywhere he went, whether it was at his local veterans meeting or on the Wall of China. He absolutely carried a VF banner with him all the time. So we hope you'll visit our website to learn more about VF Bob. Our next campaign is our V-Red campaign, which is in honor of our excellence in diagnostics. This is an annual competition that we host where we ask patients to nominate a medical professional for making a critical early diagnosis of vasculitis. We know many patients go a long time without being diagnosed, but we know there are many lucky patients who find a physician or a healthcare professional who helps them get a diagnosis early. Those are the people we'd love to hear their stories, so please visit our website and submit your healthcare professional for the award. We'll be sharing the nominees and actual winners during Vasculitis Awareness Month. One thing that's coming up immediately as of next Wednesday, February 28th, is Rare Disease Day. And we hope you'll join the VF and NORD and hundreds of other patient advocacy groups and patients around the world as we all spend time raising awareness of the impact of rare disease on Wednesday, February 28th. Rare Disease Day is an international effort to bring awareness to the impact that vasculitis has on our patients, our families, and how important it is not only to know about rare diseases, but also to support funding of research to improve our patients' lives. So we hope that you'll join us that day. Thank you again for joining us today on the webinar. We will be posting it out on the library as soon as we get it edited. So I want to wish all of you a great day. Thank you.